Okay, good morning. Thank you for joining us today. I'm Patty Gravett, the Deputy Director of the NCI Center for Global Health. As some of you who may have joined us before know, this year marks the 50th anniversary of the National Cancer Act and the 10th anniversary of this development of the Center for Global Health. Cancer Act united patients, scientists, doctors, industry, and government all under one vision to accelerate cancer research and initiate the conversation on cancer prevention. In addition, it charged NCI with supporting collaborative global cancer research, cancer control, and cancer research training. And this has been the foundation for NCI's work in global oncology over the past 50 years. The specific creation of the Center for Global Health 10 years ago grew from that foundation, and we continue to strive to ensure research done anywhere improves people's lives everywhere. So we are commemorating the NCI 50 and the CGH 10 anniversaries by launching the NCI Global Cancer Research and Control Seminar Series, which features talks by global experts in global oncology. We hope these seminars will provide the opportunity for discussion and collaboration around impactful and innovative work that addresses cancer morbidity and mortality worldwide. For today's session, and particularly, I am delighted to welcome Dr. Silvina Arrossi, Senior Researcher at the National Council for Scientific and Technological Research and Research Associate in the areas of Health, Economics, and Society, or CEDES in Spanish. Dr. Arrossi is a sociologist with a doctorate in demography from the University of Lyon and a Master's of Science in Public Health from the London School of Hygiene and Tropical Medicine. She's an advisor at the World Health Organization, and between 2008 to 2018, she was the scientific coordinator of the National Cervical Cancer Prevention Program in Argentina. Dr. Arrossi has conducted seminal implementation research, which has been supported by the NCI, to study national scale-up of self-sampling and HPV testing for the secondary prevention of cervical cancer, and we are thrilled to be able to hear more about the advances that she's made through this work today. As a final note, today's presentation is being recorded and will be available on our website at cancer.gov/globalhealth. You can find information about future presentations on our site and by following us on Twitter at NCI Global Health. So with that, Dr. Arrossi, we give you a warm welcome and looking forward to your presentation.
Thank you, Patty, for such a warm introduction. I will share my screen if this is okay. Let's see if this works. Okay. Now it's working. Okay, can you see my screen?
Yes, your screen is being shared.
Yes.
Okay. And to assure a good internet communication, I have stopped my camera. So I'm sure that this will work.
Excuse me, I believe your microphone is muted, sorry.
Okay, now can you hear me?
Yeah, we can hear you now.
Okay, perfect. So I was saying, good morning to everybody. It is really an honor for me to be part of the NCI Global Cancer Research Seminar Series, and I thank the organizers for having invited me. My presentation is about how HPV testing as primary screening was introduced in Argentina, as well as HPV self-collection, presenting results from the evidence. And I will also point out some of the challenges faced during the scaling up of the strategy, as well as some of the interventions we are considering as a response to these challenges. But first, Okay. But first, I would like to mention something about my role in the introduction of HPV testing in Argentina. Between 2008 and 2018, I was both the head of the National Program on Cervical Cancer Prevention and researcher at CEDES and the National Council for Scientific and Technological Research in Argentina. So I had this double hat, the manager and the researcher hat. So when listening to the presentation, have in mind that there was really not a divide between the implementation and the research, but it was really implementation research. So during my presentation, you will hear me say, we did, we carried out, and by that, I mean this great team that worked with me, both implementing and producing evidence. Now I'm a full-time researcher and the head of the Arrossi Lab, a team that works to produce evidence for the improvement of cancer prevention and control policies, in close collaboration with national and international agencies. So having said that, I must say that I have no conflict of interest to declare. So to go directly to the cervical cancer prevention subject, you must know that in May 2018, WHO made a call to countries to eliminate cervical cancer, a disease that is almost entirely preventable with existing knowledge and technology if screening, treatment, and HPV vaccination are effectively implemented. But more than 70 years of cytology-based screening has shown that the path between screening and cervical cancer reduction is not straightforward, and that implementation of interventions doesn't necessarily result in expected outcomes. In fact, the evidence shows that the real-world application of new technologies can be highly deceiving in terms of resulting outcomes. The reason behind this failure is that health systems are formed by 6 blocks that function in interrelated manner: the governance or stewardship, the information, financing, service delivery, human resources, and technology blocks. So you can see very clearly here that technology is only one component of the broad health system. And yet, most of the evidence, I can say, and discussion when we talk about cervical cancer prevention refers to issues regarding technology. For example, its efficacy, without considering the effect of the broad health system. Besides, to add complexity to the subject, the health system is not an isolated planet, but it operates in dynamic interrelation with women and patients whose health behavior will be influenced by a multiplicity of socioeconomic and intermediate factors. And these two interrelated social and health systems being affected by the broad policy context. How these systems and how their components are defined in each specific setting and its interconnections will modify the impact of an intervention on health outcomes. Therefore, in my presentation, I will show you how we have incorporated this real-world dynamic into the planning, implementation, and evaluation of HPV testing and self-collection introduction in Argentina, a middle-income country. So, just to put you in context, it is important to understand that in Argentina, 4,000 women are diagnosed annually with cervical cancer and around 2,000 die due to the disease. The national mortality rate is 7 per 100,000 women, which allow us to say that in the region, Argentina is in an intermediate position. For example, far better than countries as Peru, Bolivia, Paraguay, but with higher rates than Chile, Costa Rica, and of course, Canada and the United States. And one striking characteristic of the epidemiology of the disease in Argentina are the geographic and social disparities of its burden. As you can see in this graph that shows the distribution of cervical cancer mortality by provinces, for example, the province of Misiones has a mortality rate that is 3 times higher than the rate of the city of Buenos Aires. And here we are in the poorest areas of the country, and here in the bottom part of the graph, we are in the most developed areas of the country. And in the country as a whole, women suffering from cervical cancer are the poorest and live in the least developed areas. And yet, cytological screening has been available for more than 50 years in the country. However, historically, it was affected by a variety of problems. In 2008, we did a situational diagnosis that showed that screening activities were affected by a variety of problems: the low sensitivity of the test, the lack of an organized program, the low screening coverage, which was focused on young women with over-screening, lack of follow-up of patients with abnormal results, cytology reading carried out in small laboratories without quality controls, and the lack of an information system. And now, since the last decades, the situation has changed, because the understanding of the link between HPV infection and cervical cancer has led to the development of a highly sensitive and reproducible test based on the detection of the virus DNA. HPV testing has been shown to reduce cervical cancer mortality, and its high negative predictive value allows extension of the screening interval. And this is very important because it helps to simplify strategies and activities needed to achieve high screening diagnosis and treatment coverage. It is the recommended text in a context of HPV vaccination, and very importantly, it allows self-collection of the test by women, with a potential impact in the reduction of social and geographic barriers to screening uptake. And I always say that for me, this is one of the most revolutionary aspects of HPV testing. So between 2012 and 14, we carried out in the province of JUJUY a demonstration project to introduce HPV testing. JUJUY is located in northern Argentina, in the limit with Bolivia, and in 2012 was one of the country areas with highest cervical cancer mortality rates. A situational analysis done in 2007 has shown that the screening coverage was low, information on follow-up and treatment was missing. It was impossible to know what happened with the positive women after the diagnosis, impossible, no data on that. For example, providers had low adherence to programmatic recommendations. For example, although the norm established screening from 25 years of age, screening of very, very young women was very common. Or although the recommendation was to screen women every 3 years, annual screening was very common. Cytology results were read in 6 laboratories which processed sample without quality controls. Very, very small laboratories. So the JUJUY demonstration project, GDP, to make it shorter here, established HPV testing as the primary screening test for all women aged 30 years and over, receiving healthcare in the public health sectors. It was also established that women younger than 30 would continue to be screened with cytology. Cytology was established as a triage test to identify HPV positive women who would need immediate referral for colposcopy and biopsy if necessary. But it was established that HPV testing and pap smears were to be taken at the same time, but cytologies were to be read only if the HPV test was positive. And this only for clinician-collected tests at health centers, because it is not possible to do double sample taking when the woman performs self-collection. Hybrid capture 2 was selected as the screening test, as at that time was the only test approved by ANMAT, which is the Argentinian regulatory agency. And women HPV positive with an abnormal pap test were referred for colposcopy and biopsy if necessary. So now I will show you part of the results from a qualitative study we carried out to evaluate the implementation process of the GDP, which was published in the e-Cancer journal, where you can find the complete analysis if you are interested in learning more about the process. For this analysis, we used an adaptation of the health system framework, presenting 4 dimensions instead of the original 6 blocks, which are the stewardship or governance, the funding, technology, and the organizational capacity, where we grouped blocks referring to the service delivery, human resources, and the information system. So very briefly, to give you an idea of the type of work we did, regarding the governance dimension, the GDP was established as a collaborative project between the national and provincial ministries of health, with the active participation of key health departments, for example, primary health care, and stakeholders at a very early stage of the design and planning process. An important component of this planning phase was the development of guidelines and algorithms for screening, diagnosis, and treatment, which were established through consensus, a consensus process that included representatives of the main national scientific and medical societies. The project was also discussed in several meetings with national provincial authorities, and its final design was agreed on through consensus. And this consensus was a key characteristic of the JUJUY demonstration project. In relation to the organizational capacity dimension, it would be very long to describe all the changes that were carried out, but I would like to mention some of them. The first one is that the HPV laboratory was established as part of the cytopathology service at the main hospital in the JUJUY province, the Pablo Soria Hospital, which centralized from that moment reading of all cytologies from women aged 30 years and over. And an essential component was reorganizing the referral network for diagnosis and treatment, as well as training of health professionals with refresher courses, for example, on colposcopy and treatment techniques. And we also organized a system of patient navigators to increase adherence to follow-up and treatment of women who were HPV positive and also had abnormal pap smears. And a special focus was put on the design of the communication outreach strategy, including educational materials, both for women and health providers, both graphic and audiovisual for local radios and TV channels. This is an example of the leaflets that were given to women when they to promote screening, and also to help them understand the meaning of the test result. In relation to the information, we created a module to register all events related to screening, diagnosis, and treatment in the National Screening Information System, which is called CITAM. So a specific module was created for this. In relation to the financing, this is a very important issue of the GDP, because first, all the funding came from national sources, and the national government funding all the tests, HPV testing, the training, and the communication materials. Whereas the provincial Ministry of Health funded the local health providers, diagnostic and treatment infrastructure, and the system for sample transport. And services were provided free of cost to women as part of the national health insurance systems, where people attending the public health sector don't pay for the services. So that was included as part of the universal access to healthcare that we have in Argentina. Regarding the technology, well, international evidence on HPV testing performance was the backbone of the project. It was really the basis for the national regulation to introduce HPV testing, and was disseminated among health authorities and providers through several scientific meetings and seminars with the participation of well-renowned national and international scientists, which was key for increasing local knowledge and understanding about the methods. This is the picture of the national seminar carried out in 2010, where representatives of provincial screening programs discussed available evidence and agreed on introduction of HPV testing through a demonstration project. So there was a wide acceptance among national leaders of the scientific and medical community about the effectiveness of HPV testing and the need for changing the paradigm of cervical cancer screening. At that time, introducing HPV testing was felt as if an opportunity window would open to change ineffective processes that had been operating for decades with no effect in cervical cancer control. So really, HPV testing was seen as this golden opportunity. So now I will show you some of the quantitative results of the GDP. We did an analysis through a population-based before and after retrospective cohort study using data from the National Cervical Cancer Prevention Program. And for that, we compared key outcomes for the cytology-based period during 2010 and 11, immediately before introduction of HPV testing, and we compare these indicators with what happened during the HPV testing period of the GDP. For this presentation, I'm only showing results for the clinician collected test. So in total, 44,700 women were HPV tested in the period. And you can see that compared with cytology-based screening, the odds ratio of being diagnosed with a SIN2+ lesion was 2.3 when screened with HPV testing after controlling for age and health insurance status. So we can see an important improvement in the effectiveness to detect disease with HPV testing. But improvement of all other programmatic indicators were also observed, for example, in relation to the number of laboratories, which was decreased from 6 to 1. You know that centralization is a key aspect to assure quality of a laboratory. There was also a reduction in overscreening from 7% to 0, a reduction in the proportion of inadequate samples from 4 to practically 0. And for example, there was an increase in adherence of health providers to the recommended age from 79% in the cytology-based periods to 100% in the HPV testing period. So important improvements in, we observed important improvements in a variety of key programmatic indicators. And based on these results, scaling up of HPV testing at national level was initiated, and at present, 11 provinces are offering HPV testing as primary screening in the public health sector. So let's talk a bit now about HPV self-collection. What happened with HPV self-collection? Well, as I mentioned before, a main advantage of HPV testing is that women can take the sample by themselves. This is really important, no? Because, for example, in Argentina, there was a wide discussion about, for example, if a nurse could take a sample, because there was some oppositions from gynecologists to a nurse taking a sample for a cytology. And now with HPV self-collection, we say, well, let's stop the discussion. Now the woman can take the sample by herself. So it's really a change in the way we understand screening and sample taking. And international evidence has shown that HPV self-collection is effective to detect disease and is accepted by women from a variety of settings, with huge potential to reduce barrier to screening. Nonetheless, translation of this acceptability into packages of care in Argentina raised several key questions. Who should offer HPV self-collection and where? Would it be accepted by local women? And could we replicate the level of effectiveness to increase screening uptake observed in studies carried out in other settings? What are the main limitations of the method in our context, and what interventions could be developed to overcome those limitations? So, to understand how we introduce HPV self-collection, it's important that you know that in JUJUY, 700 community health workers belonging to the public health system visit houses twice a year for provision of several services, such as immunization. And we thought that the real difference could be made in coverage by combining HPV self-collection and a delivery system based on community health workers offering it during their home visits. So in 2012, we carried out the EMA project, a mixed method study that included a cluster randomized trial to evaluate if the strategy was effective to increase screening uptake. So very briefly, around 200 community health workers were randomly selected and assigned one-to-one to the study arms. HPV self-collection offered to women during home visits, and a control group of community health workers who promoted usual care. This is clinician-collected HPV testing at health centers, because you have to remember that at that time, HPV testing had been already introduced as the primary screening in the province. And women in the intervention group could opt to use self-collection or to go to the health center to be HPV tested by a health professional. And the study showed that the strategy, the intervention, resulted in a fourfold difference in screening uptake between arms, 86% versus 20%, an impressive difference in the intervention group in relation to the usual care. And results from qualitative and quantitative research we did as part of this project showed that most women accepted the strategy, as 85% of women in the intervention group preferred self-collection instead of attending a health center to be HPV tested. And when we asked women why they preferred self-collection, they said that they saved time, and with that, they were able to overcome barriers related to domestic and family care responsibilities that prevented them from attending health centers for screening. Regarding adoption, the acceptability of community health workers to include the offer of self-collection as part of their programmatic task, 89% said that they would accept to include it as a programmatic activity. And this is very important because community health workers are like we call them the firemen of the health system, because they have a lot of responsibilities, a lot of duties, a lot of things to do during the home visit. So to add an extra activity, it had to be accepted, and most of them accepted that. And finally, when we asked health professionals about their acceptability of the strategy as a programmatic tool, we found some opposition, but in general, it was accepted if used to increase participation among socially disadvantaged women. An important result of the EMA project was the definition of the 4 main core components of the strategy. These were the training of community health workers and what should be included in the workshops to train them, the offer of self-collection and the steps to follow during the actual visit, including provision of information about cervical cancer prevention and HPV testing, the meaning of the results, and a 10-minute step-by-step explanation on how to perform it. The third component regarded sample handling and transportation to the health center, and the fourth one specified follow-up and treatment referrals. In 2014, HPV self-collection was extended to the whole province and became a routine programmatic strategy to increase coverage. And from 2015, the strategy was scaled up at the national level, and at present, 5 provinces use it as a routine strategy. So the scaling up process generated new questions. For example, do community health workers accept it to incorporate it as a routine practice now outside the context of a randomized control trial? And is it effective in this real life context, programmatic context, to reach the target population? And what are the main limitations when applied at scale? And what is the level of fidelity? Or there are some adaptations that could compromise the effectiveness of the strategy. So to respond to these questions, I will present very briefly results of 3 studies that used implementation science to improve the scaling up process. A mixed method evaluation of the scaling up, a fidelity study, and a mixed method study to evaluate effectiveness of an mHealth strategy to increase adherence to triage. So the evaluation of the scaling up was carried out using the REEM framework, which is a framework particularly appropriate to assess the public health impact of an intervention, taking into account key dimensions: the reach, the effectiveness, adoption, implementation, and maintenance. So the analysis showed that self-collection, that year we analyzed women that use self-collection in the first year of the programmatic provincial scaling up. We saw that 10% of the very hard-reached women, these were women without health insurance that hadn't been screened for the last 5 years. In only 1 year, 10% of these very hard to reach women were screened with self-collection. And this resulted in a 40% increase in screening rate in that target population. Adoption was still high, with 70% of all community health workers working in the province, the 700 now, offering self-collection. And we also saw that there were few implementation problems in the screening phase, but there were some problems to assure triage of positive women with only 70% of women with triage and diagnosis, which resulted in a reduced detection rate when we compare it to what was achieved in the randomized control trial of the EMA project, a reduction of around 10%. So a main conclusion of the scaling up study was the need to develop new strategies to increase triage and diagnosis among positive women who have performed HPV self-collection. The second study was to evaluate the level of fidelity. And for that, we did a study in the district of La Matanza in the Buenos Aires metropolitan area, a setting completely different from JUJUY, the northern province where self-collection was introduced and developed as an intervention model. You can see the picture of La Matanza here. La Matanza is an urban setting with 2 million inhabitants, 30% of which are poor and live in very difficult material circumstances. Insecurity is a main problem, and the primary healthcare system differs in many aspects to the JUJUY system. The most salient one here is that health promoters are not salary workers of the health system, but women from the community who receive some sort of economic support from the social development ministry. The study main question was how far the implemented intervention actually adhered to the prescribed model established in the EMA project. And it included observations of health promoters during the offering of self-collection, evaluation of training workshops, and analysis of data on triage, diagnosis, and treatment. And results analyzed so far show that there has been a high level of adherence of fidelity regarding the training and the sample handling and transportation core components. However, we did detect adaptations in the offer of self-collection, which are mainly the result of the different social urban contexts where women live and their relation with health promoters. So we found, for example, that due to fear of insecurity, it was very common that women won't let health promoters enter their houses. And the offer had to be carried out at the house's front doors. You can see the picture here. As a result, the contact was shorter with fewer pieces of information provided to women and less time for the whole offering. This did not impact the quality of the sample taken by women who did accept self-collection, but it might have an impact on the overall acceptability with less women accepting the offering. So now we are analyzing what happened and what was the actual impact. And we also observed that adherence to follow-up was challenging with a reduced level of triage when compared to levels obtained in the EMA randomized control trial. 75% of women had triage, compared to almost 80% in the randomized control trial of EMA. So again, we identify a problem with the level of triage of women who have performed self-collection. And this reduced adherence to triage was also observed in the analysis of data on HPV self-collection we carried out in the province of Tucumán in northern Argentina. This is a province close to JUJUY. And we can see here that 120 days after the test result, only 26% of HPV positive women had performed triage. The percentage increases with time, but at 120 days, the percentage is only 26%. So a problem with time, and we know that time is important in the line of care to prevent cancer. So to finish, I would like to present the third example. In this case, a study specifically designed to improve the follow-up process by increasing women adherence to triage. And to do this, we designed and evaluated an mHealth-based intervention that integrated HPV self-collection, community health workers, and a screening information system, and text messages sent to HPV-positive women to communicate with them to inform them that the results were ready and they should attend the health centers to be triaged. And the intervention also included sending text messages to community health workers if a positive woman had not triaged 60 days after the test result, and this in spite of having received the text messages. The study design followed the structure of an effectiveness implementation hybrid type 1 trial and used a mixed method approach. It included formative research to devise content and framing of the messages, a pragmatic cluster randomized trial to test effectiveness of the intervention, and research about the acceptability and implementation of the strategy. So now, if this works as it should work, I will show you a very, very brief video about understand better with images what this study was about. I hope this works. Ática busca dar respuesta al problema de la adherencia al triage en el marco del tamizaje con test de BPH para la prevención del cáncer cervicuterino. Intenta facilitarle el acceso a esas mujeres que son BPH positivas al PAP de triage. Se randomizaron, sortearon más de 200 agentes sanitarios que invitaron exactamente a 5.351 mujeres de todo Jujuy a participar del estudio.
Vengo a visitarla.
¿De visita? Pasa.
¿Permiso? Yo lo invito a participar en un proyecto que se llama Ática.
Por el tema del numerito de teléfono que usted me dio, le mandan un mensajito de aquí a 30 días.
Para que usted ya tenga la accesibilidad de ir al hospital o al centro de salud a saber su resultado. Directamente mediante el celular le va a llegar el mensaje y le va a ser más fácil para eso, para que se acerque.
Encontramos que en el grupo de mujeres que recibieron los mensajes de texto, el 71% de las mujeres que eran BPH positivos hicieron el PAP de triage, versus el 55% en el grupo de mujeres que no recibieron los mensajes de texto, es decir, el grupo control.
Aquí están los resultados de BPH. Ahora te voy a programar para que el doctor te haga un PAP. No te asustes tampoco porque te dio un positivo. Si hay algo mal, se trata con tiempo, es curable todo. ¿Sí?
En el marco de la prevención del cáncer cervicuterino, nos muestra que una estrategia de bajo costo que no implica una sobrecarga para los agentes sanitarios es efectiva para que las mujeres puedan continuar con la línea de cuidado y así acceder a la prevención del cáncer.
Como a mí me ayudó eso, así que puede servirlos a otras personas también.
So, very briefly, the study showed that most women accepted messages. For them, they represented the close link with community health workers, while these workers considered messages as a facilitator of their work and link with women. And the intervention was effective at increasing triage adherence among HPV-positive women with a 19% improvement in the intervention group due to the mHealth strategy. suggesting, as you could see in the video, that mHealth technologies can have a key role in communicating with women with reduced access to health services to increase their adherence to follow-up. So to finalize, I would like to stress some conclusions. HPV testing in the context of Argentina was really an opportunity window for major changes at the health system level. So this is an important role. It's not only its efficacy and recognized effectiveness, it's all the changes that can be done when you have to make such a major change at the health system level. The laboratory network was reorganized with simplified processes, centralization, and increased quality. There was a high consensus about HPV testing performance, which resulted in higher adherence to age recommendations by health providers, for example. And this is a key change. HPV testing doubled detection of SIN2+ lesions, and HPV self-collection was effective to increase screening and uptake. There are challenges also. Adherence to triage of HPV-positive women with self-collected tests is a problem. And we see that in the end, this ends up reducing effectiveness of the strategy to detect precancerous lesions. So it is very important to address this problem of adherence to triage. And mHealth technologies can have a role in communicating with HPV-positive women, assure triage, diagnosis, and follow-up. And also, we have to be very attentive and careful about the adaptation of the strategy and monitor if there is a change that might compromise its effectiveness. So fidelity is an important issue when implementing an intervention. So to finish, I would like to stress that HPV testing was really a key opportunity for us to change the history of cervical cancer screening in Argentina. But we really had to take into account that technology is only one part of the universe of the health system, and we have to take into account all the components of the health systems to make it work. Changes are needed at the level of health system organization because HPV testing can be an enable, a driving technology, but it cannot. But what it is not is a miracle pill. And this is important to understand it. So I would like to acknowledge all the institutions that supported and participated in this implementation and studies: the Ministry of Health of Argentina, the Argentinian National Cancer Institute, the Ministry of Health of JUJUY, IARC-WHO, Secretary of Salud of La Matanza, Harvard University, Deakin University from Australia, and the NCI and NIH for its funding of the Attica project. Thank you very much.
Sylvia, thank you so much for that. As you know, I am a huge fan of your work and particularly the health systems approach that you're taking, because I think we all need to recognize what you just said, that the health technology is not the silver bullet. We need to take into account the whole universe of implementation. So we're happy to take any kind of questions in the chat. Let's see, I'm just looking at one, if you give me 1 second. So this is from Isabel Scarinci. Governments tend to be very reluctant to self-collection because it's not FDA approved in the United States. So how did you convince the government to transition to self-collection in the provinces?
Well, as I said, it was really thought as an opportunity to reach women. to reach hard to reach women, if I can say, although it is kind of redundant. Because the issue, if you really, we established coverage goals, and the only way to reach those goals who were established and discussed at very high level of the National Ministry of Health, the only way was to use self-collection. It was not possible to reach those goals only using a clinician-collected test, because you have to acknowledge all the barriers faced by women, not only social and geographic barriers, but also barriers of the health systems. Simply, there were not enough sample takers at health centers to perform screening and reach the coverage goal. It was like the recognition of that impossibility. And then HPV self-collection was supported by international evidence showing that it worked. And it was like really this opportunity window for changing a public health policy, no? And it was like being in the right time at the right place, and it worked. It was really relatively easy. I won't say that it was easy, because nothing is easy when you are making changes at the health system level, but it was relatively easy. We didn't find any strong opposition, really.
That's fantastic. I agree. Sometimes when you just put it to people of what you're missing when you just simply don't get women screened, I think some of the other issues become less relevant. So here's a question, Silvina, from Diane Harper, who's his great presentation. Are there triage strategies for those who test HPV positive, who then are triaged to PAP and their PAPs come back as normal or no malignancies, and then follow up at a later time? So how do you manage essentially those who have a normal PAP but were HPV positive? Do you recommend more intensive repeat screening?
Yes, a woman that is HPV positive and have a normal PAP are recommended screening at 18 months. And what we have observed is that around 50% of them comes for that rescreening, and for the rest, there is some work to reach those women so they come back for this rescreening. So a possibility is also to use text messages and mHealth strategies to communicate with those women. So we can stress the importance of that rescreening.
Great, thanks. I think those are important data as well in terms of the long-term sustainability of these kind of triage strategies. Jose Geronimo is asking, he understands that doctors opposed HPV self-collection at the beginning of the project and is asking what is their attitude now? And I guess I would follow on to that to say if their attitude has changed, what do you think was the tipping point for them?
Well, at the beginning, we have to think that we are in 2012 when we introduced HPV self-collection. And now the situation is completely changed because the level of evidence at an international and national level has also changed. But at that time, it was really, there were really very few studies analyzing HPV self-collection, and we were highly inspired by the work by Eduardo Lascano with the MARCH study in Mexico. So there was some opposition because they thought that women might not understand how to take the sample, or the community health workers wouldn't be able to explain how to do it. But in the end, they said, okay, but we understand that we have these coverage problems, and we have these socially disadvantaged women with difficulty to access a health system. if self-collection is for them, it's okay. So at the beginning, it was said that self-collection was only for women without health insurance who hadn't been screened for more than 5 years. And then the situation changed with the years. And now, for example, that we are still facing the COVID pandemic, which meant that people are reluctant to go to the health centers. In fact, now they are reluctant, but in 2020 and beginning of 2021, they weren't allowed to go. We couldn't leave our houses. And doctors and health centers were so busy dealing with the pandemics that thinking of providing screening was also a difficult thing. So now at the National Cancer Institute, they are even considering providing self-collection in health centers. It has become a much more accepted strategy. And I think there is no longer this opposition because the COVID pandemic has changed everything on top of that.
Great, and I think we have time for me to combine a final couple of questions from Ricky Liu and Hawa Kamara. Given the triage adherence issue that you've observed, which you've addressed somewhat with the mHealth, have you been thinking at all about using other kinds of options like an HPV-16, 18 genotyping direct to ablative treatment on the same day, or even just in general HPV screen and treat strategies?
Well, it's also, I mean, everything is always considered because the evidence is being updated, and now we have the new WHO guidelines and recommendations and the cervical cancer handbook by IARC that we will see very soon. So the evidence is changing, but one thing you have to take into account is that HPV testing is bought by a national Ministry of Health through a national tender process. So there is an issue, this is implementation, and it's an issue of prices and the possibilities you have in terms of simplified process of logistic at the field level. So for the moment, this equation of effectiveness, price, and logistic issues has resulted that hybrid capture 2 continues to be the test, okay? While identifying women with 16 and 18 HPV can be very important, you still will have different status of women you will have to deal with. So it's something that from an implementation point of view has to be thought very carefully, what adds to the simplicity and what adds to the complexity.
Thanks, Silvina, and I agree. I think that simplifying these strategies, at least in the short term, until people can normalize some of this into their health systems, and then possibly looking into, other kinds of options that, further increase the risk benefit could be an important strategy. And I think one of the things that I'm coming out of with this is that we all have so much to learn from each other about implementation. So I'm going to ask you one last quick question, and that is, how can we best summarize this information together so that we can give best practices to the other communities who are attempting to do something exactly as you guys have been doing in Argentina?
Well, I think, I'm a person formed in implementation research. I think that a key issue is to do implementation research, monitor what you're doing, your interventions, and I think that's the key message. Just looking at the effectiveness or efficacy of a test and say, okay, it works, it will work here,
that's not the correct approach. It takes time to do implementation research. Is not easy. It is not always understood by health authorities or funders, but it is important to do it, because I always say that if we don't do that, we will make with HPV testing the same mistakes we have been doing with cytology screening, and that will be a really sad story. I think we have in our hands the possibility of changing the history of cervical cancer prevention, but we don't have to be naive. We really have to understand the complexities of the issue and the role of implementation research to assure success of the intervention.
I completely agree, and I think that you're doing a lot to help advance us into what kind of implementation measures are really the important ones that we need to collect, both to reflect on how well we're doing and continuously adapt and improve the system over time. And I think I also wanted to just echo what you said, that new screening strategies, the step changes that we're talking about, like moving from cytology to HPV testing, open up the opportunity for people to reflect back on their health systems and improve them in ways to adapt to new technologies that can then, strengthen the systems in many other places, which I think is fantastic. So with that, I really want to thank Silvina for her excellent presentation. I think this is phenomenal work, and just invite everyone to continue to look to our website and our Twitter feed for the upcoming speakers. Our next speaker is going to be on November 2nd. It's Donna Shelley from New York University School of Global Public Health, who will be speaking about implementation science, evidence-based tobacco use treatment in Vietnam. And we really look forward to that seminar series. And then we're looking towards a really exciting 2022 seminar series to follow. So again, thanks to everyone, and with a special thanks to Silvina Arrossi.
Bye-bye, and thank you very much.